Hey everybody, it's Chris Pamil, and on today's Whiteboard Wednesday, we're talking about cardiac meds in pregnancy. So on other videos, we talked about high blood pressure in pregnancy. Most of the medicines we use in pregnant patients is for high blood pressure. Of course, the most important part is to talk with your OB/GYN. The reason is that they spend their whole training on what's safe, what's appropriate in pregnancy. So I can speak from a very small part, predominantly in the high blood pressure space. There are a few medicines we think about most importantly for pregnancy. They're actually not the most common medicines we use all the time. The reason is that these medicines have been around for a very long time, so there's a lot of data behind these medicines, specifically in pregnant patients. So there's a pregnancy classification that all medical societies use. The reality is that there's either real-world studies, there's randomized studies, observational studies, or animal studies. So the best type of data to get from is people who have been randomized studies. So the most common medicines we use in pregnancy are labetalol, which is a 2 to 3 time a day drug, nifedipine, which is a 1 to 2 time a day drug. These are the cornerstones of what we use. I know we're in the hypertension space, but I see a lot of patients with high cholesterol, hyperlipidemia. And I just want to discuss that it's actually very unsafe for pregnant women to be on this medicine. I'll tell you why. In my primary prevention world, when we start to talk about high cholesterol, and I know we've talked about this in other instances, but if I have somebody who's younger and female on a cholesterol medicine, we have to have a frank discussion about life goals, pregnancy plans down the line, because all cholesterol medicines, so statins, like rosuvastatin, atorvastatin, etc., Lipitor, Crestor, same thing. These are all excreted in breast milk and they all cross the placenta. The problem with statins are they reduce, well, the benefit of them, they reduce lipids. The problem with that is that lipid development is extremely important in babies because that's where brain development comes from. You really should stop 3 to 6 months before in an emergency case. Usually about 6 weeks is acceptable, but for me, since it's primary prevention, we try to balance risk and benefit. So I'd rather somebody be off a cholesterol medicine for 6 months to guarantee that there's nothing residual left in the body for baby. So I usually say 3 to 6 months off of statins. And if somebody is on other blood pressure medicines, I will slowly transition them off, because not only do you want to be off the medicine, but you also want to have controlled blood pressure. So I try to wean them off the medicine, titrate them onto another safer medicine, and get it to an appropriate blood pressure before they start to think about children. So again, I know a very complicated topic. There's a lot of doctors that all work together, but this is just my overall approach to how I approach the younger patient who could become pregnant when you start to think about high blood pressure and cholesterol.